So, welcome everybody. I am Professor Bogart. I am the lead pediatric professor. So, anything that you need that I can't help you with, the next person to answer to will be Dr. Brown. I don't mind you going to Dr. Brown for anything, for any reason. I don't get yelled at. I don't get scolded. I don't get demerits. In fact, we work together beautifully as a team. I help her, she helps me, and that's the way, again, what nursing is all about. Um, I've been at Fortis for quite a while now, since 2017. I taught pharmacology, I taught peds, I've helped with med surg a lot. I've also taught a community course. So I know what you all are going through right now in this semester, most of you with 3 courses. So I've taught them, I know what they're like, and I understand your angst and anxiety in pediatrics. I'm going to try to help you. There's one big project due, and it's week 8. And I'm going to warn you, week 8 is a heavy, heavy week. I would not wait to the last week to do that project. I'll go over that a little bit more when we get into the PowerPoint that shows the online things that you're going to hear for your both of your online courses. But I'm just going to tell you what is makes the difference for me. What do I expect from you as students? And there's just one word, and that's communication. Talk to me, let me know what's going on, I can help you. Before something is due or before a test is done, tell me before. Don't tell me after I can't do anything. Tell me before I can help. And I will be here and I will be helping you. So some of you do know who I am, some of you don't. Uh, with pediatrics, I do 2 different things when I teach. I do the conventional PowerPoint, but no, I don't read a PowerPoint. I tell you the gist of the PowerPoint, the concept I want you to know, and I explain it simplistically. That's first thing you'll get. Also, because of a student, except for week 1, every week is going to be each chapter PowerPoint differently than instead of all together. And I used to do one big lecture PowerPoint, and then I would do a cahoots, all of the chapters. Well, I had a student 2 terms ago and said, why don't you, after each chapter or each, like if you're talking GI, let's do a little cahoot about that right now. And I did it last term. It was the first term. I actually saw better exam and quiz grades. I could see that there was absolutely a difference. Instead of giving you all the information and you try to muddle through it, each one separately gave you that little bit more of, oh, I got that, instead of not so wishy-washy of what did you remember about that concept. So that's what I've been doing, and you'll be getting all of this stuff. You'll be getting the PowerPoint. You have it already. Any handouts will be on your announcement. You have a lot of announcement, a lot of handouts there this week. You have one on week 1 matching, very important. You probably quiz type questions will be on there. I would look through that. There is something on Erickson, it's called, but it's about theorists. And this is basically how these big doctoral people do research on children and what do they look at, whether they look at it through a sexual lens, whether through looking at how they children respond to other people, all age people, or how they think and how their mind, their cognitive growth occurs. So we're going to go over all that. I'm going to try to make it a little simple for you, but you have a handout to start looking at it. I don't send a lot of announcements to you. So if I send you an announcement, please read it. You usually will get one for the beginning, which gives you what are we going to do this week? This week was welcome to NUR203 pediatric nursing, and it gave you all your information, all your handouts. When we were done with class, I'm going to be sending the recording and I'll resend the PowerPoint. At least I do that one. If there's something you can't open, always let me know. I'll just resend it to the whole class, because if one can't open it, maybe the whole class doesn't. So I always take that as a hint. Somebody sends me, I'm going to send it as a in Canvas as a message. They usually send there better than on the announcement. So just keep your eyes out open for that, okay? The second announcement that you'll see on the week is after class. And usually within 1 hour after class, you will see the recording posted. Okay, so that's two announcements. If you see something else that's added in there, it's important. It could be on the schedule for um, week 3 exam reviews because your first exam is week 4. So looking for that is a great information. I'm going to attach all the Cahoots. I'll be attaching all of the information there you need. One place, one stop, one shop. Go get all the information you need to study for that exam. That's what I try to do to help you all keep organized. Because I know there's some professors that send 18 announcements every week, whether you want to read them or not. And I know I'm not lying here. So if I send one, please just open it up, take a peek, because it's usually something interesting or something you need to know. I don't just send extraneous things. I just don't. And if it's something for a person, it'll be directly to you, reminding you, hey, you didn't do your NCLEX questions, or oh, you forgot to do this discussion post, or whatever it is. That will be only to you. But any announcements, please read them. So we're going to start off first with, quote, the rules of online, right? We can call it that. And we all have our own PowerPoint, but they're extremely similar. Dr. Brown made them, and then I like to put different things on them and pretty pictures. And I don't know, I have a problem with just keeping it plain and simple. I think pictures and things tells 1,000 stories, and that's why you're going to see my PowerPoints are just full of pictures. I think a picture can tell you more than a lot of words sometimes. So remember, in online, it means you got to be online at a certain time and be set up and appropriate. I don't mind if you eat or drink at camera because I know you guys are busy. 3 courses, working, families, children, house, everything. I get it. You're overwhelmed. So if you have to eat at this time, it's fine. Just, do it with, not like licking your fingers and, all those type of things. Be a little bit with food etiquette, okay? I don't mind drinks at the bedside. Also, I have a question for all of you. I can go straight through tonight and not do a break, and I can get you out of here about 30 minutes earlier. Is that something that you would all want to do instead of getting a break in the middle?
Yes, please.
Sounds good to me.
Yes.
Yes.
Okay. All right. I've heard a bunch of
Yes.
yeses. Okay. Most people do, and I usually don't have to go to the bathroom or anything like that. So, yes, I'll go straight through with you. Keeps my train of thought too, As you get older, you need that train of thought to keep rolling. So anyway, if you need me, you can always contact me on email, Canvas message. I'm always looking at my phone. It's connected. I'm always looking at emails, making sure that any student needs anything. I don't check it first thing in the morning, but usually after 10 is usually when I start checking things. And I'll check them up till before I go to bed at night, sometimes up to 8, 9 o'clock at night. So there's a lot of time that I'm there looking and I'll be answering your emails. If I don't answer an email in 24 hours, something's wrong. Resend it. Okay. That means I didn't get it or it got mixed in the bunch of emails. Something happened because it's not like me not to answer. Okay. So in this online forum, you have a professor. I'm your professor this class. There's also a course lead in every course. I am the course lead. So when you want to go and you need to talk to someone about an issue, first of all, you go to the professor. The chain of command is so important here that you follow it, okay? If I can't answer it, in my case, you would go directly to Dean Brown, okay? Also, you can also go to your own dean on campus if I can't get you what you need, okay? But first, it's always Dean Brown. And then, I don't know if the woman ever sleeps. She always answers emails, phone calls, text messages till I don't know what time of the day or night. But she will answer you quickly to give you whatever answers you need or whatever the problem is that I couldn't help you with or that I didn't get back to you quick enough and you needed a quicker answer, okay? My cell phone number is there, and that is my real cell phone, 305-951-8055. You can text me, you can call me, but do it when there's something you need to know now. That, for instance, and I'll give you the example. Let's say you are trying to do your project and you have these 2 hours this time of the day to do work because of your busy schedules. And I understand you got to put time slots when you could do stuff. And you need to know an answer so that you can be able to do that project. Well, that would be one that you would text me or call me and say, hey, I need help with this right away. Any other time, you could just send me a message in email or Canvas, and I will get back to you quickly. If you want to text me, or you can go through the Canvas. When you are talking again, just remember being courteous. We do look at the professionalism with everything we do because when you're done and you pass your boards, you are registered professional nurses. So professionalism is always what we look for. That's why we do this in nursing school too, as in how do you talk to and how do you approach people, and you do it in a proper manner and all that, like not putting caps on a message. I never knew that was a bad thing until somebody told me. He goes, yeah, they tell you it's like they're yelling at you. I'm like, okay, well, I don't put caps and I never did, but I won't do it for sure. So remember that there is a lot of online assignments and stuff that is going to be there. The discussion board this week, it's due tonight, right? If you haven't done it, don't be upset. Get it in the first week by Sunday. I'm okay with that. But be aware that first discussion board, ask me about who you are, why you want to be a nurse, but there's a second part, and it's about nutrition. And the one thing that you're going to hear me say, I can't even tell you how many times in a term I'll say it, is nutrition, nutrition, nutrition. If a child does not get proper nutrition, they're not going to grow or be cognitively aware enough. So if you don't put gas in the tank, it's not going to go and it's not going to be what you want it to be. So nutrition is probably the most important thing that we give our babies and our children. Academic integrity, plagiarism, and cheating, and all of those things that I know that nursing school is difficult. And I know that it's a lot of time to be spending on some of these projects. So you think that they're just a lot of, spinning your wheels and spending time, and you don't understand. Well, all of the things that are put into this program are there to make you understand a certain concept of some sort. So it's not just that busy work that you are doing. So plagiarism, make sure you don't take cut and paste from a source directly on for a discussion question. Just take the words and change them up and then put the reference down there, and that's all you have to do. It's not that difficult to change it like that. I mean, cut and pasting is easier, yes, but it's going to get you in trouble down the line. And plagiarism can eventually get you thrown out of school. And I don't want that for anybody, okay? Cheating. Cheating has always been a problem, will always be a problem. And all I'll say is cheating, you cheat, you're going to hurt yourself. I think that we do the best we can to try to eliminate as much cheating as we can, but it's still going to go on. And again, you're hurting yourself. I was not an A nursing student, guys. I did my own work. I didn't cheat. I was too afraid, not from the teachers, but from my mother. My mother would have beat me up really hard, and my life as I knew it would have been over. So my GPA when I graduated nursing school was a 2.28. I barely got through, but it was all mine. I did it. I passed the boards. And then, of course, my later degrees, I'm a 4.0 GPA. Yes, I'm a nerd, honor student, etc. But letting you know that nursing school is hard. Just do your best. And cheating won't help you. Now, there's a lot of AI help today. I see it a lot in discussion questions. Be very, very careful with it. Just let me know what AI things you're using and be aware, is all AI scholarly? Where did it come from, too? Okay. Again, just basically code of ethics, being those professionals. That's what I want. Now, a couple of years back, we found that there's a bunch of these websites, and Fortis is all over it, and Studaco, Coursera, Stuvia, and there's many, many more out there. Those are just the three big ones that we had found, and students were posting everything there, from discussion questions to any handouts that were given, papers that were written, and students were just copying and pasting and sending them in. All of your information that comes to me is run through a plagiarism checker. So don't do it, because if I see high levels, I've got to say, hey, you need to change this, or I have to report it to your dean. And depending if it's happened before, you could be, thrown out of the program. And I don't want that. So if you are going to these sites, know that I don't even those sites. We don't know if they're scholarly. Nobody knows that those informations are correct, and we have found a lot of information that's incorrect on them. So I wouldn't go to them. Just use your resources, like you know how to go do them, or go to your LRC and have them help you how to look up resources, because that's the better way to go. Now, homework. Homework is always due on Sunday night, 11:59 p.m. Eastern time. Okay. So when it's due at Sunday, and I have not been told by you, there's a problem. I can't get it done. My computer, it broke. The dog ate it. The screen went black. My husband's sick. I don't feel good. I'm in the hospital. All of those excuses and many, many more. If you didn't tell me before it was due, you still have one more week. You can hand it in, but it will be a minus 10% deduction. Okay, be aware. I will work with you as long as it's in every single assignment. I will work with you, and I will give you that grace to be able to get it in without deductions. Attendance. Now, you were wondering why we have a week 12 quick attendance meeting for that half hour. Well, if you do week 12, there's no attendance. And then for week one, for some reason, and I just have a student right now who can't make week one for whatever reason, okay? She would have been out 14 days in a row. And guess what? She's dropped from the program. 14 days without, being on, any sort of attendance, you will be dropped. So making sure that you do come in. All right. Also, when you come in, your full names, and everybody did that for me. Always keep the camera on your faces. I don't want to see anything but faces there, to know that you're with me. I like checking around. I check faces, seeing who's like closing their eyes and just thinking, and who's like looking at me and going, oh, okay, I can understand that. I like doing that. So your faces help me also get through this uh, our class here today. Know that I don't care if you're in a car sitting that's not moving, a passenger, a driver in a car is absolutely no. We cannot do that. There is a lot of legalities involved with it. You're in a classroom in a car. So it's a lot of legal problems with it. So we cannot allow that to happen. Okay. If you are in a car, you need to stop, get somewhere, do your class, and then you can continue to go if you're traveling, if that's what has to be done. Okay. As I said, we will be doing attendance, and 1 minute after the hour is 15 minutes late. At 16 after, that's 30 minutes late. You can see every 15 minutes there's going to be when we look at them. Of course, you'll be letting know if you're 5%, 10%, 15%, whatever late. You're going to know that. Now, on online, you don't have to wear your uniforms. They haven't mandated that, but please be professional. Don't wear, I mean, it's winter now, so everybody's wearing more cover-up clothes. As it gets close to summer, I get to see tank tops and stuff, and we would prefer things that cover up, our body parts, okay? No jammies, no see-through clothing, and be careful of people behind you. I've actually seen husbands getting out of showers and stuff like that, and I don't want to see things like that. So just be aware behind you, things happen. I've already told you about attendance every 15 minutes. Know that 20% of being out for missed attendance, you will drop one full letter grade. Now, stuff happens where you've gone to the ER or you had to take your child in or your mother or something happened. There was a funeral, there was something that you can give me documentation that shows me why you weren't in class. I will give that to Dr. Brown and she will excuse that attendance so you won't go over 20%. Okay. So be aware if you have to be out, if you can get documentation, get it. Whether it's the electric went off, the internet went off, you can get a piece of paper from the company, shows me these things. I can get that to Dr. Brown and she can help you with that attendance so it doesn't give you a full letter grade. Okay. So be aware. That's what I just said. So they've got a new slide in this term. It's about, alcohol and tobacco, drug abuse, the testing, et cetera, et cetera. And it's just basically, you know, there's no inappropriate use of legal substances. I've had students sometimes try to vape on camera, whatever they're vaping, okay? They shouldn't be doing it. So I did send them a message and it's not been done again, but we don't do that. Again, any sort of substances that you are on that are prescribed. The dean of nursing needs to know them if they are mind altering type drugs, okay? And as long as you have a prescription for them, the dean of nursing will evaluate that, okay? So one of the reasons we talk about all of this, no drugs and alcohol, et cetera, is remember, we're going to be professional nurses and we don't want to put out an image of being unprofessional by using these things out in the publics, et cetera, et cetera. So it's not just class, we're talking about a lifestyle, trying to be, the best professional you can be. So every week you're going to get that first announcement. Usually it will come out on Saturday night, midnight. And what it talks about is what assignments are due, what chapters we're going to cover, any handouts, and the PowerPoint. When you go through it, look at what assignments are due and make a plan for when you want to get them done, okay? The NCLEX questions, be careful. The first set of NCLEX questions is not on pediatrics. It's on above it, it's a growth and development topic. And you have to do the click down and do infants, toddlers, preschools, school age, and adolescents, okay? And that will give you the ones that you need in order to do those NCLEX questions. Be aware, if you've done NCLEX questions and you see a 0, go back and look at the comment in the NCLEX questions. It's going to say, you didn't do the growth and development. Please submit, and I give you a week to get it done, okay? They say always look into your log, look at your announcements, know what's going on. Again, try getting the assignments in on time. And the other thing I'm going to tell you about the quote homework assignments, that busy work, make sure that you get a 78 or more on it. I can't tell you how distressing it is for me to have a student pass KGA. And because of homework and they didn't get big enough grades, they fail the course and have to repeat. So be aware it can happen. So get your 78 and the homework's not going to, hurt you. And you know what your KGA is all the time here. So one of the things, please take my number, put it in your phones, have it there. And any problems, please contact me. Let me know what's going on. I know that most of you have already gone through that pre-check, doing the checkoffs to be able to get into your Canvas shells. So that is good. It's also there under Professor Bogart. My cell phone's there. My Zoom is there. Information. Again, have it so it's handy in case you can't get to a computer or a phone or whatever. It would be nice if you came to class already have looked at the PowerPoints or looked at the materials for this week. Because then I'm going to discuss each of those chapters and go over them. And then after each chapter, I'm going to give you a Kahoots. And if you did that once breeze over before you came in and maybe have questions. Then you listen to me lecture on it. And then you've done the Kahoots, which given you a quick quiz test on all of the concepts. It's going to be more embedded in your brain. So it behooves you to come in prepared, okay? If there's any problems, again, with your Canvas shell, emails, anything, make sure you just fill out your help desk ticket and it's on your front page, on your home page. You can do it. I don't do weekly quote review sessions. What I do is this. I can come earlier to class. I can stay late after class. I can come to any time that you want that I'm not teaching or have one of those mandatory meetings. I can make my time yours to get with you to review. Most students like to do this like right before exam one. That's fine with me. Just make sure you send me a message. We'll work on a time and we will get together. It could be one of you or a group from your campus. Whatever you want, I'll work with you and help you. Anybody who's a repeat or re-entry, please get with me because we need to do weekly tutoring. That's the only one you don't have a choice. We need to start meetings starting next week, okay? Your KGA, your unit exams, your quizzes, and your HESI. That's 80% of your grade. The rest of it is 20%. Is high hitting in NCLEX, those case studies, and the big one is also the pediatric assessment project. This is the one I'm talking about that you need to think about early. Now, this is under week eight's module, all the information regarding it. What I want you to do right now is start thinking about a diagnosis that could be pediatrics, whether something you had, your child had, your mother had, your uncle, your next door neighbor, a friend, or you saw it in the hospital somewhere and you want to learn more about it. Make it interesting for you, okay? I love getting different diagnoses and syndromes that I've never heard of before. I got two last term and it was very exciting for me because then I learned something new again, right? So, with that pediatric assessment, start thinking what diagnosis? Is it asthma? Is it ADHD? Is it Down syndrome? Is it seizures? Is it Duchenne muscular dystrophy, tetralogy? I could go on and on. Now, they do have a big list on Module 8. You do not have to use one of them. Think about what diagnosis you want to learn about, and that's the one. Send it to me, let me approve it, and then you can start working on it. When you start working on it, if you get a section done, you did that 250 word paper about what that diagnosis was, send it to me. I'll correct it. I'll send it back so you can get a perfect 100. You can do that, but you can't do it the week before, the week of that assignment due. It must be before that I can do it. I've got 3 classes. I've got about 75 students just in my classes, not counting all the other ones I watch over. So I can't do it that week, but I can do it earlier, week 3, 4, 5, whatever you need. I can do it for you and get it back to you. Now, something that we do, yes, Asia, you have a question.
Yeah, so if we send it to you and get it approved and everything, do we turn it in early or do we have to just hold on to it until week 8?
No, this is one of the things that's open. Discussion, NCLEX, and your week 8 project are all open right
Okay.
now. And there are multiple submissions that you can give to it. So you can do it that way, and
Okay.
that would be fine. And then I'll be writing comments in the comments as you see me going down. Okay?
Okay. Sounds good.
Okay.
Thank you.
No, you're very welcome. Very good question. So one of the things that we do is we have the homework grades that we turn on in the end, right? And that 20%, how does it affect your grades? Well, one of the things that we saw is some students didn't want to do their homework or not do it as well as it should. And we were seeing homework fails. And what can we do to try to stop that? Because some of them were like, I didn't know that the homework did that. Well, this is why we have homework grades turned off right now. So only things you're going to see is KGAs, which means you're going to see a quiz and you're going to see an exam. Week 4, 1 through 4, that's all you're going to see. And then the homework, you're not going to be able to know how does it affect your grade. Well, on week 6, we turn it on. And what we show you is the homework grades and what does it do to your KGA? Does it go up or does it come down? And that's going to let you be aware what's happening. Now on week 8, we turn them off. And we will not turn them on until the very end where all the remediation's done, and that's your final score. So just to let you know, be aware of your homework, please. We already know you need a 78 and a 78. Now, for quizzes, you don't have to come in on a phone for me, okay? You can come in on your laptops. I do my own check that way. And then we do our quizzes within Canvas, okay? And there's an access code, so you can't get in it without the access code. And the one thing I'll tell you, don't ever give an access code to another student. I'll do it, okay? Some students come in a minute or two late. I know you want to help. Don't do it. I can do it, all right? Because I have to put them through my little check I want to see, okay? Students always want to help. I know that. Quizzes. I make all the quizzes for all of the classes. I make a quiz bank. So they have 30, 40 questions and they can pick their 10 questions out, but it's all on the concepts of week 1 or week whatever the quiz is going to be. Your quizzes will be on the week before. So next week, you're going to be having a quiz. It's on this week's information. That's why I'm telling you that matching might be a good thing to look at. And the Kahoots that we have later on, another great thing to go back and look at concepts. Do I understand those things? Okay. The KGAs are 10 questions. They're for 15 minutes only. You can only go forward. You can't go backwards. And no quiz can be made up for any reason. If you're in the hospital, you were in an accident, nothing. You can't make it up, all right? But what if that quiz, that little fraction of a point, puts you over the 78? If you show me documentation, I'll give it to Dr. Brown and make an appeal. She probably will let you take the quiz. That's the only time, okay? I have many students. Can I make that quiz up? No, it would be in the end of the term if you really need it for your KGA, okay? Know that quizzes, exams, all the time, your face, your whole face must be on camera, not that sliding off to the side or a camera going up type things. Must be on camera. I can't tell you, some students did get zeros on exams last term because they were off camera for whatever reason. Now, I will be sending you messages in the chat. Hey, hey, hey. I also might, and this is the only time I'd interrupt an exam, is say, hey, Asia, get back on camera, please. Right? You would prefer me to do that on camera to get you not getting a zero. And I know your other classmates were like, oh gosh, all right, she's back. Okay, she doesn't get a zero, because that's, what the only time that I would do that. Exams are through ExamSoft. I'm going to be sending you one of those, example ones that you practice ones you can go through. Know that your ExamSoft works before you come to the first exam. I'll tell you why. If you haven't gone through and done that practice exam to show that your computer and everything is set up and can work for ExamSoft, and you get on the first day and you cannot get into your exam, you weren't prepared. You could get a minus 10% deduction because you can't take the exam that day. Okay? Be careful. Make sure that you do check to make sure that you have that there. Okay? Now, ExamSoft is directly through your computer, so you need a second device, phones, iPads, and the next thing is please make sure they're charged, or please make sure you have chargers. Don't tell me the charger doesn't work. Don't tell me it's in your husband's car. You left it at school. It's in a friend's bedroom. It's been all over the place. Please, those are excuses. If that computer shuts off, because you didn't have a battery, okay, how do you explain that? It's not being prepared for work. It's not being prepared for your exam. If you're going through the exam, and we're in winter time right now, so things could happen, hailstorms, so snowstorms. I'm from the New York area originally, so I'm from Northeast. I live in Homestead, Florida now, which is 30 minutes from the Florida Keys. So I'm in the warm area now. Yeah, I know I'm an old lady who likes the warm now, like the water and love the ocean. But let's say it's sleeting and it's snowing and your electric goes out and the internet goes out and you're in the middle of the exam. Everything shuts off. You're going to go, oh my God, it's my exam. It's lost. What am I going to do? First of all, take a breath. Your exam is never lost. It's always there. Just immediately let me know, hey, my internet, this just turned off in any way you can, whether it's on messaging, whether it's on my phone. Anyway, get a hold of me and let me know. And I'm going to tell you why that's important. Because once you text me, email me, message me, there's a timestamp. And when I go back to the exam, I can see every time you clicked A and then unclicked A, or clicked A and B and then unclicked B and put C and D. I know every time you touch the computer. Yes, I can. And I can see, yes, that's when it happened. Yes, that's when she called me. I validated that was the time. We can get together at a time where it's convenient for you, and I can get that exam started exactly where you stopped. Okay? It's not lost. You don't have to do it again. All right? Sometimes some students like to be proctored on campus. I don't mind that at all. It's no problem with me. But there's two things have to be done. Number one, I need the proctor to email me and let me know they're proctoring you. It has to be done on class time, okay? And you yourself need to tell me such and such will be proctoring me on campus. So now I've been validated by you. You're going to be there. And the proctor, I know that it's a valid proctor because I'll check to make sure that you're getting proctored properly. And I will give them the access code. I'll make your own exam for that campus and you can take your test on campus. I have no problem with that at all. But it must be done with proper protocol. We know it's all Zoom. I'm going to be checking IDs. Make sure you have your ID or a driver's license on exam day, okay? No hats on the head. I know some of you like to put a hat on your head for protect your hair. During exams, no. A headband, okay, not a hat, all right? Your ears have to be showing. And if you need earplugs, those little foamy things, I need to see them before they go in the ear. Let's say you woke up and you're having massive GI issues and you cannot take this exam. Tell me before. Now, if you go to the ER or to the doctor, give me that documentation. So now I've proven that you were sick. I'm seeing the documentation and we will reschedule your exam for another date and time. All exams must be made up within 7 days of the class. So today is Wednesday. So by 5:30 next Wednesday, if today was exam day, your exam must be already taken, okay? If you do not notify me and just don't show up and don't take the exam, you still can take the exam in 7 days, but it will be a minus 10% deduction. So again, communication, right? One thing that we're asked a lot is, I wasn't in my right mind. This and that was happening during this exam, and I need to retake it. They do not retake exams for any reason. They just don't. If you sat down to take the exam and you knew there was a problem, you should have told me before. That's the concept there. As I said, your quizzes will be in Canvas and you will see them very clearly lit up, and the access code will get you going. Your first one next week at the beginning of class, so be on time, okay? Again, it's talking about technical difficulties. Again, just stop. Just stop. Again, like exams, quizzes, I see every click you put on those too. So if you click off the screen and try to go on the internet, I know you've done it. So please be very careful during those. Don't do that, all right? The HESI exam is only one time and it's on week 11. It is 20% of your grade. I've got a lot of HESI prep stuff to help you out, okay? I've got some Kahoots, I've got a PowerPoint, I've got a HESI Q&A that I do it the Saturday before to try to help you think. Like if you get a question that looks like this and it's on this GI about vomiting, what do you look for? How do I, remember these things? Not just remembering information, it's the application is what I try to do. Most students tell me that it does help them a lot. Your grade, you should get a 900 above. I mean, my mean grades for HESIs is 900 and above on most of my classes. So if you do what I tell you to do, you study your Kahoots every week when I give them to you. You study your PowerPoint for your exams. You come to work to class ready to ask questions. You have things about you don't understand. You're going to do well. For exams, you study all the Kahoots. You study the study guide. You listen to my review and maybe another one. You're going to do well, but you've got to put in the effort. I give everything to you, but you've got to use them, okay? I've put a lot of effort and time in there. I change them every single term because I want what works better to make it better and easier for you. These remediation times, I'm going to put them in an announcement in the end so you don't have to worry about remembering them. I mean, if you're above 900, 1 hour is nothing to do on them, right? We know there's going to be ID security. If there's any problems, you always talk to me. And then homework. This week we only have a discussion question and to prepare for quiz number 1 on week 2, okay? I like writing my stuff down. I know most of you are into the technical age and you put it on your calendars and you know what's all going on, or you follow Canvas, whatever works for you. Just make sure that work is getting in on time, but know that you do have one more week to get it in. But after that 1 week grace, there is no extensions. That's it. It's done. Unless you told me what's going on and there's extenuating circumstances before it's overdue, okay? The NCLEX questions. The first set, I've told you, make sure you do growth and development. It's not pediatrics, the first set. Your NCLEX questions, it's open up, the due dates, but be careful because you always have to post every week 2 times in the Canvas shell. So making sure if you did it too early that 1 week you might not have enough postings in there. And that's part of your attendance too, to let you know, all right? The NCLEX questions, I don't want them submitted on that little green little square type picture. I want the big printout because I want to see what areas you've done, okay? If you're seeing an NCLEX questions, you did them, but you're seeing a 0 for the grade, go into the grade book and look at a comment. It's going to tell you what was wrong. And I will give you extra time if you turned in the wrong thing, okay? Just to let you know, just go and look. I'm not going to give you a 0 and not tell you about it. NCLEX questions, turn in your best score. You can do them forever you want. I'm telling you, please get a 78 or higher minimum on these, okay? And once they are submitted, that's it. I've had students who at the end of term say, hey, can I redo those NCLEX questions and get a higher grade? I can't because you already clicked enter. They're already submitted, okay? There are 2 in Evolve. It's called the HESI RN practice and assignment exams. They're due week 8 and week 10. There's been some times where we couldn't go through the module to get to them, but if that happens, again, this is something that let me know. I can't get in it. I can't do it. And I'll figure out an alternative way for you to get there. Okay. That's what that means. When you're doing them, know that the score should automatically transfer right over, like your sim chart and your RN practice assignment exams. They should just already go over. Now, if for some reason they don't access back to your Canvas, put in a help desk ticket. There's a problem. Let me know. I'm going to find the grade. I can go in there and look for it. I will find it. But also just to make sure that the rest of the grades are going in properly, okay? Your sim charts, know that these have to be done when they're scheduled. There's no open due dates on these, okay? These were new last term. Take your time. You've got to read the initials in order to do them. I've got one student who has an assistant director who did a video on sim charts and how to do them the best way. I'm getting that, and I will be sending that to you once I get that. I'm going to send it to all the PEDS people. I'm going to look at it, make sure first, and then send them. So the paper, this is your assessment project. The assessment project is, again, it's week 8. There's a rubric there to follow, and know that you need references on it. It's a project, 2, 3 references, not just one. And know that you need to cite down in the body of the paragraphs which book, which reference did that one come from that you're talking about that fact about that disease that you're doing, okay? And they also want you to make sure that you do more recent, newer articles. They say no more than 5 years old. And Dr. Brown put this in there in the end, and it's just basically talking about, taking nursing school and what you're doing and assignments you're getting done and applying them to. So if you didn't do your assignments in nursing school, did you do the treatments in nursing for your patients? You should have, so it's basically, again, being accountable for your learning and then in your future for your patients. Any questions so far? No, I haven't put you to sleep yet. All right, let's go to our first PowerPoint. As I said, this is the only time they are all in one. Okay, starting next week, each chapter is going to be separated, and there's going to be a Kahoots for each chapter after that. This week, there's one PowerPoint, there's one Kahoots, all right? So chapters 26 through 30, it's a lot of them. It's a lot of extraneous information. Many of it's repeated over and over and over again, okay? But it's basic overview here. Now, Healthy People 2030. When I started nursing school, I had no clue what Healthy People was. When I went back to get my higher degrees back in 2010, I went back to get my BSN, my MSN, and my PhD. Well, a lot of times in nursing school, you have to write papers about a lot of different stuff. And you got to figure out topics that you want to learn, talk about, in your papers or PowerPoints or projects, whatever you're doing. Well, Healthy People is these government programs that look at certain health disparities and tries to improve them through different ways. I mean, we know that presidents' wives have always chosen something like exercising more, like Obama, get out and play, right? Or other ones, reading, going to the library, or eating healthier, school lunches. I mean, there's all these things that the government look at. Well, there's all of them listed right there for children. That if you're looking to do a project, they're all great things that are looked at. And that's why I mentioned them. Healthcare for children, big childhood problem is obesity and type 2 diabetes. Why are children obese today? They're not out in the backyard playing like they used to, riding a bike. They're inside on an iPad and technology, right? That's what I see. Or they're afraid to be outside today, depending on where you live. Um, and remember, when they are obese children, they will become adults that will end up with problems with high blood pressure, cholesterol, and diabetes. So it's something that needs to be addressed. Childhood injuries. Kids tend to have no filter. They tend to, oh, I want to do it. They do it. They go and do it and they get hurt. And it's just kids and learning. Kids can be violent. Vaping is a big thing today. And mental health and children. You're saying children have mental health problems? And the answer is yes, they do. All different varieties. I've seen from just a depression. I've also seen that the schizophrenia, where they were seeing paranoid delusions and seeing a child not being able to control themselves. It is a very hard thing for me. So I've seen some very severe mental health issues. Infant mortality. Well, when I started into newborn ICU, it was back actually in the 1980s, believe it or not. That's how long I've been in this field. And I know that little itsy bitsy babies didn't really have a big chance back then. Or if they had a chance, they had all of these different side effects, brain bleeds and problems with digestion and food feeding because of their intestines. And, many of them died. Okay. So there are two words in that first year of life that you need to know. The first 28 days of life, you are called a neonate. So it's neonatal ICU. It's the first 28 days of life. After that, up to 1 year of life, they are called infants. Okay. That's the difference in names and why you hear those different of names. Now, infant mortality in the United States is actually still pretty high, although it's a lot less than it used to be. And I can tell you that because I've watched 40 years of change. I've watched it get much better and more improved. Okay. United States, we think that we would be like number one in healthcare. We are not. Talk about Switzerland and Norway. Those Scandinavian countries are actually better healthcare and less infant mortality than we are. I mean, a lot of it's a lot to do with low birth weight. Now, children, they're into everything. Death rates. Well, the first year of life, the kids have all these diseases, they have no immune system, and they have a chance of dying greater than any other age. So death rates greater than 1 year are not as bad as infants because their immune systems are better, etc. Now, their accident rates go up, but their death rate goes down. And then you've got the children now, they're older preschooler and they are now older children. They have the lowest death rate. It's because they've learned to ask, they learn to understand things that can hurt them. But then look at the adolescent. All of a sudden, they think that they're adults and think they can do what they want, adolescents, right? I was a single parent with two teenagers. I remember it very, very well. As I always said, I held on for the roller coaster ride. And they actually turned out okay, but it was a difficult time because of they just learning, trying to figure out who they are. Remember, adolescents, all of a sudden, they get more doing injuries, things like hanging off cars and rolling them around and trying to flick them off, or standing on cars and riding, or jumping from here to there, and you shouldn't be able to do that, and playing with guns. And then the other thing is suicide. Um, Adolescents have a really hard time mentally with their image, identity. Some adolescents don't like themselves at all. It's their identity and their role. Like, what am I going to be when they grow up? And they're almost that grown up, so they got to figure it out quick now. So that's all about injuries and whatnot in kids. So childhood morbidity. So we've talked about, the young kids. Now we're talking the older kids. The areas, the groups of children that have increased morbidity, homelessness. Well, you can figure that out why they don't have proper, sanitation, food, sleeping, heat, comfort, anything, right? Living in poverty, not getting proper food, maybe just barely living in a home or an apartment, low birth weight, chronic illnesses, cystic fibrosis, sickle cell disease, rheumatoid arthritis. I mean, I could go on with the amount of that. Foreign born adopted. We don't know, what's gone on with those children. And then the last one, I think most of you go, huh? Children in daycare centers, increase in childhood morbidity. Why is that? Well, what do kids do all day long in these daycares? They play, right? When they play, what do? Everything goes in their mouth. So it goes from this mouth to this mouth to this mouth. They swap spit between each other all day long. So any germ one kid has, they all have them by the end of the day if they're all playing with the toys, right? That's what kids do. You can't change it. And that's why that increases. So pediatric nursing is family-centered care. Family-centered meaning that it's not just the kid. You've got a whole family to deal with. Many nurses don't want to go into pediatric nursing because of the mother and the father. And mothers and fathers can be quite overbearing sometimes. I actually was that nurse that got all the most difficult parents. For some reason, I could calm down the worst storm and get them calm. And I think it had to do with I just listened. Why are you so upset? What can I do to help you? And then teaching them how to take care of their kids. That's basically all they wanted. They're just scared for their child. So know that the family is the constant in that child's life. They don't know anything else but family, especially younger kids. They're barely around any other people but their family. Another thing about pediatric nursing, and we're getting a lot better with it, is atraumatic care. As in everything we do for that child should be done with less stress, pain that we can provide for that child. One of the things I did as a nurse in the research committee at the hospital I worked at is I developed a program specific to atraumatic care. It was Huggies, H period, U period, G period, it's the acronym. Help us give great injections efficiently and safely. And what I did, I proposed and researched was that children from all ages, from infants up, that when the mother was there holding them, it was very evident they had less stress, pain, and fear before, during, and after injections because they were in mommy's or daddy's or whoever caregiver's arms. And it's some program that's still working today, and they still use it because it makes sense. Again, we're trying to do it as little as possible, less pain as possible. You go into an ER, you need an IV. Do you ever get numbing stuff on where they're going to stick that IV? Oh, no. And they use the biggest lumen IV needle, don't they? They put that good old 18 gauge big IV in you, and it hurts. Children, we don't do that. We could put numbing cream on it, and we use smaller catheters, and it's to reduce that stress because a young child in fear becomes an older child who becomes petrified. Nursing does everything. I think we are that counseling session between the husband and the wife, especially with critically ill children and with their brothers, their sisters, the grandmother sometimes could be a big person. So again, the nurse is there as that person, and we're there to teach, to guide, to get them home and keep them home safe and to keep them home, with their children and not back to a hospital because I taught them right. So the leading cause of death among African American boys ages 15 to 19, which one is it?
Suicide?
It's actually firearms.
Hmm.
Firearms. That's the first thing that they pick up is they go pick up the gun. They think they're cool and they can handle it because now they're 14 years old. They're a teenager and the safety's not on or they turn it off. It goes off. Somebody gets hurt. That's what happens. So dealing with children is just not children. It's just not families. It's the culture of the family, whether it's their religious, their cultural, or whatever. It's just who they are. Every person is similar, right? we're all different. So remember, a definition of a family. Now, my family was me and my two kids for many years. And then I met my husband today and the stepdad. I've been here for over 20 years now, but um, my daughter lived with me for a while. She had her baby, and unfortunately the father was not a part of that. And so her family was me, her, Christian, my little guy, and my husband, and that was our family. Now, today she has her husband, another baby boy, and that's the family. It could be two girls, it could be two boys, it could be grandmas, it could be adopted. There are just so many different types. But a family is whatever they say it is. Those are all the names for it. You can call it anything you want there. Now, when you're working with families, you got to figure out who's going to be that spokesmodel, who is that lead person, who's the role. You're going to have the one who supports and the one that needs support. For instance, you can have a father who's really strong and the wife who needs support. You wouldn't tell the mother something without the father there to give support during these times like that, right? It also shows you how close is this family and how is this child going to get the care that they need at home, right? We can look at just the family, the reaction all between them. There's all different parenting styles. You've got the parent who's the kid's friend, and they're not going to have as much discipline as that mother who is always on top of them. And you can't do this, you can't do that, and make sure. And they sit there and they're afraid to move and breathe. There's all types, and it's not right or wrong. It's whatever they are, right? As long as the kid, when they come to me, they can just listen to me and I can play with them and I can do what I need to get done, right? Parenting of an adopted child or any other child of another thing, they're all different. And, parenting is only what you know, trying to infuse that cross-racial, international, absolutely all the culture that's involved with it. There's all sorts of parenting things. I've gone into a lot of them. And the one thing, again, as I've mentioned, is you've got to understand not only the family and how they are between each other, they're cultural. You could see sometimes you see it in the school, sometimes it's not the community, the church community, right? Who are the sort of people they hang around with? What are their beliefs? It's one of the things that makes you, when you ask a parent about, for instance, you get a child in and they're from a different country and you've never worked with that country before, or you want to make sure that you're doing things right for that child. You could ask an older child, but you can also ask the parent, so is there any special things that you need from me? Some of them might be like a vegetarian diet, or my daughter should have never a male caregiver. All of these things are culture. This is things that you have to think of. So a frequent healthcare problem of migrant children and adolescents is which one? Migrant workers.
Tuberculosis.
It's tuberculosis. I live in South Florida, as I said, in Homestead. And down here, there's a lot of fruit and vegetables and a bunch of farms down here. And they do get the migrant workers in here to work them. And that's fine. Great people. But when they come to the ER, these children are usually extremely ill. They've already gone to their local, in their community, their people's medicine person to take care of the child. Then they might have gone to a doctor on the area where they're at. And now they've come to me. The one that I keep in mind, and I still remember, was this little, I think he was about 11 months old. He had 105.6 fever, and he had bilateral pneumonias and influenza. Talk about a sick little boy. Now, these migrant workers, knowing when they're coming in and they come respiratory, the first thing I always would do is put a mask on me, because number one, I'm immunosuppressed. I have rheumatoid arthritis, so I've got to be careful. But number two, tuberculosis. because it does happen, especially when you see the signs and symptoms, the sweating, the bloody coughing and spitting up blood, etc. Those things I definitely had put on a mask for and put the child in some sort of room to protect the other kids. So growth and development. Have you ever thought about a newborn infant? They're born, they don't even know how to breathe. They can't lift their head up. Nothing is voluntary. They don't know what to do with nothing. And then we teach them, smack them on their little booty, right? And they breathe. And now they cry. So now they've learned how to breathe and cry. Then we put something in their mouth and they suck. And they have to learn to suck and breathe. And then we put a bottle or a breast in their mouth and they have to suck and swallow and breathe. And then they have to learn, by 2 months, they lift their head up. And then by 4 months, they're starting to turn over. By 8 months, they're sitting unsupported. By 9 months, they're standing up. And by 12 months, they're attempting or they're walking. They couldn't lift a head, they couldn't breathe. And now they're walking and talking to me in 1 year. This is the quickest growth that happens. And I love this, interrelated, simultaneous, and ongoing. It happens so quick you don't realize it's all happening. So there's different sort of vocabulary when it talks about growth and development. Directional is how they're getting taller. Sequential is that they lifted their head and then they rolled over and then they sat up and then they stood up and then they walked. So those things that we look at. And developmental pace is, are they meeting those milestones? When are they meeting them? Are they meeting them slow or are they meeting them on time? And we know all kids are different. 2 brothers, 2 sisters, same house, all different. Same mom, same dad. Now, children, we have to be aware their vital signs are going to be different. Now, I did insert a vital sign sheet into your announcement. Now, it's not in gold, those numbers. I know PALS has their number. I mean, everywhere you look, there's going to be a little bit of variation in numbers. But what you need to know is that a neonate at birth, a heart rate could be 140 to 160. By 1 year old, that's 100 to 120. So knowing the metabolism or vital signs is going to help you look at a child and assess them better. Because if that's too low or too high, why is it? And is it really too high? I mean, is a heart rate of 140 on a 1-month-old too high? No, it is not. But 140 at rest on a 1-year-old is too high. Why? Are they in pain? Are they dehydrated? Or do they have a fever? These are things that we would be looking for, okay? We know that children, initially they sleep a lot and eventually they don't want to sleep at all because they don't want to miss anything. And then again, my favorite word, nutrition, nutrition, nutrition. The single most important influence on growth, okay? They don't eat right, they're not going to grow right. And know that all children's temperament are all different. So I told you I'm going to start to mention the theorists, okay? I'm going to, for the next 3 weeks, I'm going to be going into them and all the different areas, the ages, because it's the age that tells you what stage that these children are in. So let's look at Freud. Freud is everything about sex, oral, anal, phallic, except that word latency. That just means they like same-sex peers. Why that word? I don't know. And then, of course, adolescents are about their genitalia, right? So Freud, anything regarding that. Erickson talks about how that child reacts to people around them. So I'm going to give you the example of the first stage. Trust versus mistrust. That first year of life. Why do they trust somebody in the outside? That's what it means. It's because they cry, they get picked up, they get fed, they get burped, they get changed, and that's all they want. That's the trust. Now, what would happen if there was mistrust? Well, mistrust, and it does happen, are children that are not picked up. Not one time, but most of the time. They're not picked up. They're crying, they're left dirty, they're hungry, they're miserable, and they learn to mistrust. And you can actually, these infants don't even look at you in the eye. And they get to the point where they don't even cry anymore because nothing's going to happen. Anyway, that is Erickson. We'll go into the other levels as we keep going. Piaget. Piaget is all about thinking. So remember I told you they didn't know how to breathe. So we spanked their butt and they automatically breathe and, oh, okay, I can breathe now. We put something in their mouth and now they can suck and swallow. Well, another thing that goes on is everything that they do to learn is sensoromotor. Sensi, it's about touch and feel, oral, in the mouth. Everything is explored in the mouth, and that's Freud, everything oral. And then motor, moving it around. For instance, let's say that infant grabbed a rattle, and then that rattle all of a sudden moved, and it made a noise. He goes, oh, my goodness, it made a noise. Every time they get the rattle, now they're going to shake it because they like the noise. Well, then that rattle fell in their mouth, and they go, oh, I like that too. So now they shake it and put it in their mouth. Do you see how they build up from little things? They make it more and more and more up to formal operations, which is the adolescence. And they can formally figure their way out of a paper bag and nobody had to show them how to do it. That's formal operations. So it starts with just looking around and sensing and learning and tasting and up to then it's thinking. So language. We start out with cooing and we start out with crying, right? And why do we do that? It's because they need to be able to call out. They need to be calling for help, right? The other theorist that we talk about is Kohlberg. Now, Kohlberg is all about morals. Well, what is morals? It's right and wrong, okay? Now, infants, toddlers, so up to age 3, they really don't know right or wrong completely yet. I mean, maybe the older toddler, but not really yet. But by preschooler, ages 3 to 6, they understand there's a right and a wrong, but there's a consequence for each. We call that reward and punishment. That's what they understand. As we get older, the children school age want to please. They just want to be pleasers. And then we know when we get to be adolescents, they have to do the morality of what society says, opening the door and holding it for a woman. I mean, those sort of things in life. No smoking in restaurants, go outside. I mean, all the things you're supposed to do for normal rules of society. Another thing we need to know about is play. What do children do from the moment they wake up to the moment they go to sleep? They play, 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 don't they? So we have classified the types of play. And then I've categorized them also by age groups, okay? So socioaffective means they're in a social group with other children. Sense pleasure, that's sand, that is taking, mashed potatoes and smushing them on a high chair type thing. That's sense pleasure. I mean, you really got to let those kids try those things. Skill play, that means they've got to maybe loop a needle through a hole or maybe build things with clicking blocks. Unoccupied play, all alone. Dramatic or pretend play. Dramatic play could be something we use at a hospital to find out if there has been something that happened during a procedure and we want to know why. We do this dramatic play and that child can reenact what happened so that we can know it. And we know kids just love games and it depends on their age what we give them. So again, playing. What are toys for? It's for that sensor motor development, right? We've got to learn how to touch. We need to know how things taste. We have to know things move, figure things out. How do they work? Is basically what they're trying. It's that intellectual development. But as we're playing, it's socializing with other kids. They're being creative, right? And we know they know how to play right in a group. So that's the play. Now, types of play. We have the onlooker. We're looking at someone solitary, they're alone. And then the next three. Parallel play is two lines that do not touch, but they're parallel to each other, right? It's one child here, one child here. This one has their toys, so does this one. They don't share. Me, mine, mine. I'm not sharing. Toddler, okay? Parallel play. Now, associative play is two or more children, but they all play together, all the same toys. They don't play in making something together. They're all just playing with all the toys. That is now your preschooler. Now, cooperative play goes into two or more children playing with all the toys, but there's a goal. Whether it's building a sandcastle, whether it's finishing a racetrack, whether it's playing checkers, there's a goal. Somebody wins, something happens, there's an ending to it. You need to know those plays. Toys encourages children, especially tummy time. They're trying to move and they're trying to get that toy. They're trying to get to it, and it's wonderful for their muscles, okay? And it's also that time where mom and dad and baby brother and sister are down there trying to play with them. It's a great time for bonding. So developmental assessments, something that we're going to be doing in pediatrics every time we see a child. And what we're doing is we're making sure the child is on the level that they should be. And as we go on next week and the following week, we're going to be going into what are those stepping stones. I'll give you one example. A child should double their birth weight at 6 months. And if they haven't doubled it, that's what we need to know. Too much, too little. Do we need to feed them more? Oh, we got to. They're not getting nutrition. Or are they overfed? Are we overfeeding them? So again, developmental assessments are what we need to do on your children. There is specific ones for children with disabilities. And usually whatever hospital center you work at will have it. And it just is usually these checklists that you go through just to see, are they where they should be, or where are they really? There are a lot of genetic factors that influence children at birth. It could be a syndrome like Downs, or it could be an abnormality. Cleft lip, I think, is one of the big ones. Club feet is one of them. Again, knowing that these can happen, and then, of course, giving them whatever they need to help them fix them. So communication. Remember HIPAA. You're always going to see a question regarding HIPAA on your NCLEX, guaranteed. They just love the question on it. HIPAA and making sure that the hospital records are safe. The other thing is in pediatrics, an 18-year-old child, cognitively aware, can sign for their own care. The other thing, and this is where you have to be careful, you cannot tell the parents any information about that child unless the child gives their permission. That's the stickler in pediatrics. I've been there in the middle of some parents and children before, but it's the child what they say. So talking with families, because you're going to have to, you got to get in an admission assessment, right? Or you got to find out if you work in the ER, what's going on, so I can take care of the child. So first of all, you need to encourage the parents to talk, tell me what's going on. But if they're starting to go on and like they're telling me about the last 10 years of life, I don't need to know that. I need to know, why are you here today? What is the issue this time? Another thing, as we are listening, is, of course, you're silent, you're being empathetic, yes, but remember culture. There's some cultures where you can't touch the person, or you shouldn't be staring them in their eyes. You'll learn it as you go on. It's not something maybe you not learn the first 2 years of nursing, but there are some cultures, and I've had to be very careful with that. I'm a toucher, I'm a hugger. I had to be very careful with it. So, again, cultural awareness, because when you go against that, it can put some blocks to communication. And then this is what I'm saying is if you are not sure, ask. Ask the parents, ask the older child what's appropriate if you have any questions about anything like that. And then with any child that you cannot understand, get an interpreter. Never use an older family member, an adolescent child, because they're going to put their own feeling on the interpretation. You're going to usually those blue phones we use. Now, talking to young kids, how are you going to talk to them? Well, first of all, when you're talking with an infant or any kid, it must be on their developmental level. Older kids, toddlers, preschoolers, I give them a sticker and they're happy. I give it to an infant and they look at it and put it in their mouth and they don't really care about it, right? But if I took a little rattle and go goo goo gaga and it'll shake it some, now that's communicating. And I can see by that movement how the kid is doing. So again, making sure it's on their level. Another thing, I'm not a little girl. And if I stand above them, I look threatening. I always get even below them, at least eye to eye. But I used to even go even lower just to show them I was not a threatening nurse. Make sure when you walk into a room, especially if there's multiple adults there, who are you going to talk to? Because all of them are going to want to answer your questions. And you don't want 4 or 5 different people just yelling answers at you. You want to make sure that you're getting the person who knows what's going on. And again, the chief complaint this time. And then you're going to be looking at if they've had a cough, you're going to be looking at the kid. Do they look like they're respiratory distress? Are they breathing okay? Is their color okay? Are they tachypnic? Are they, retracting? What's going on? When you're doing the history on children, especially even going into the ER, we want a little quick ER history. When you go to the floor, we'll want an even more involved one. But we want to know at birth, did you get hospitalized right after, or did you go home normally? What do you eat? Dietary. Any other previous things that's gone on with you? Allergies, medications are very important. And then the other one that's so important is immunizations. There are some parents that don't want their kids immunized for whatever reason. And it's not for me to question that, okay? That's their decision. But I need to be aware of it so that if a child comes in with symptoms, let's say upper respiratory, that could be upper pertussis, I want to put on a mask and get that kid in a room so they're not going to hurt anybody else. That's why immunizations would be my number one priority on this child to get them where they needed to go. Growth and development, are they up to where they should be? And then habits. Do they like a certain binky? Do they like a certain blanket? Parent walked out of the room for a second and the kid's crying. I see his favorite toy, his favorite blanket on the floor. I can quick grab it for him, right? Habits are important to know. When we get the kids a little bit older, getting sexual histories. As we get to adolescence, I'm going to be talking about how to speak to adolescents and get the parents out of the room. Many adolescents won't talk in front of their parents, but if you open them up, they might talk to you as a nurse. And then you're always looking at that family structure. Is the mother in charge here? Is the father here? Or is the grandmother? You need to know where we need to focus our attention. Who's going to be taking care of this child the best? Also, knowing things like their school adjustment. When I get a child, a young kid in, and I start sitting down and talk with them, I'm like, oh, you're in school. So what grade are you in? And who's your teacher? And what's your favorite subject? And I said, so what grades do you get? I'm hearing he's cooperating, talking to me, something he's interested in. And I know that, all right, this kid's going to be listening to me. Another thing I'm looking at is parent-child relationships, especially if they're in an ER in a room or in a hospital in a room. Walk out You leave them there, come back to check on them. And if that kid has pulled everything out of the drawer, gauze and alcohol and tongue depressors and the otoscope's off the thing, and you're like, okay, this parent has not even watched this child, you know that this parent doesn't have much control. So it will make you take control of the situation. As I said, knowing dietary, knowing if there's any specific type of foods they will or will not eat. Also, if they're made, if they're telling you they're vegetarian, the one thing we should do is assess their nutrition, making sure, get the dietitian up there, making sure that they're not iron deficient anemic, okay? Because when we avoid certain foods, there's certain deficiencies that can occur. So making sure they're not. And that's what the evaluation of nutritional assessment means. Now, when we assess children, it is never, never, never head to toe. It ain't going to happen. Adults, they teach you head to toe. Children, forget it. You start out basically where their complaint is. If they're complaining of a cough, fever, you would be more wanting to listen to the breath sounds first. Because children, you are new, you're a stranger, danger, and they don't want you touching them. So let's get what we need first, and then slowly, as we build trust up, let's do the rest of that assessment. It does decrease the stress. Another thing, put them on the parent's lap. That's the best place for a child to get an assessment. And also use play, especially for those younger children. One of the things with children is sometimes they've got to go for procedures. Um, Even starting an IV or even inserting a Foley catheter. Um, the children need to know, especially the ones that are old enough to understand. You need to explain what's going to go on. The other thing you need to explain is that if there's any pain involved, any pain, you need to be honest. Children don't forget that you told them it wouldn't hurt and it hurt. Now you're a liar. They don't forget it. So always be honest. It's better to be honest and to say, I'll do everything possible to make it as little as possible. That's what you do. And then you'll hold their hand or whatever they want you to do for whatever procedure. So which approach would be best to use to ensure a positive response from a toddler? It's your hardest level child to take care of, I think, toddlers.
A.
Absolutely. Because you want to get at least an eye level, if not a little bit lower than them, because now you're not threatening. And you're going to talk quietly, you know, where they can understand you, and now they're not going to be as threatened. If you start talking loud and it's fast, that kid's going to be afraid. So, assessment, there's all sorts of things we do. Every single visit to any sort of pediatric visit, urgent care, ER, being admitted, or at a doctor's office, the first thing we do is a height and a weight. Why do we do a height and weight on every visit? Well, nutrition, nutrition, nutrition. We want to make sure that they're eating right and their height and weight's growing the way it should. Also, on infants, we're making sure, you know, height and weight. Could it be a cardiac problem that we're worried about? Fluid problems. We're worrying about, could be hormonal things, endocrine things, could be thyroid glands. All sorts of things affect height and weight. So it's the one thing that we monitor all the time. Have you seen the amount of blood pressure cuffs that we have for children? One of them is the size that goes over my little pinky. That's how small they can go. You know, physical assessment children, I think they're the first thing is a visual, that general appearance. Are they well or sick appearing? When a kid don't feel good, he's going to look sick. And kids don't lie. They're going to look sick. And when they feel okay, they're going to look okay and they're going to act okay. Lymph nodes in a well child, you should not be able to feel them. Looking at the abdomen, we could see very easily just by inspection, auscultation, palpitation, Genitalia is looked at because sometimes it's ambiguous at birth, so we should look at that. Sometimes females, their vagina lips fuse, and they need a hormone cream for it. So important that we check it. I mean, we might be the first person to see it to help that parent or that child. And then at birth, you were taught in OB to take a rectal temperature at birth. Why? You want to see if the temperature is okay, that it's an accurate one, right? Well, you're also making sure there's an anus. Not all children are born with an anus, believe it or not. So that's why we do a rectal temp, just to be sure. I mean, we check everything on them. Head circumferences is done on infants to make sure there's no hydrocephalus or anything going on. At birth, their heads are huge. Their chests are smaller. No, by 1 year, 15 months, the head and the chest should be equal or the chest should be bigger, okay? That's one of the growth and development things. And we would be measuring abdominal circumference for anything to do with feeding, right? Young infants, we'd be doing it. The height, getting a proper height on children. It's not easy to put a little kid like that underneath a thing to get to see how tall they are. They think that piece of wood's going to bop them on their head and hurt them. So I would go first. I would put it down. I'd tap it. Go, oh, look at my number. And then we put the girl on, and she would just, oh, it's good. Go, what's your number? And we would, yeah, you got a great number. Look at that. Make it fun. And that's all they want. Because push it in there, try to slam it on top, they're not going to sit there. And it's not what you want. Blood pressures, the 40% of the upper arm, that's how you measure it, but it can be put anywhere. Do you know on the younger kids, the toddlers, the preschoolers, I like D. I like on the lower leg. It's least threatening. It doesn't hurt as much. That hurts on my upper arm. It pinches me, but that lower leg is okay. So I think about that when I'm taking care of kids. You know, in cardiac, we're going to be taking for extremity blood pressures, so upper and lower, so everywhere. And then the last chapter, which is pain management. Now, pain management in children, we didn't really look at this much for many, many years. And then we just really, back in the early, it's only like 20 some odd years ago, JCAH, the Joint Commission, came out and said that we're not taking care of our children's pain. Now, we know children still, even today, with all the focus on looking for pain, identifying it. Pain is part of the fifth vital sign. Every time you do vital signs, you do a pain check. But we still, a lot of nurses are afraid to give narcotics and strong drugs to children, even in doses which have been proven that are safe, okay? But it's they're saying, all right, let me give a half a dose. That's too much. Or, oh, let's wait a little bit longer in between. Or they didn't go back to check them after they gave the medicine. Did the first dose work? And then what about the distraction part of pain assessment and management? How about if they just had abdominal surgery, elevate the head of the bed, because maybe it'll take tension off their belly. Or maybe they're sickle cell, they want heat, or they might cold, you know, positioning them. All of these things all combined can all help. Now, we have to rate pain. There are 3 scales that you only need to know. One is called FLAC, one is called FACES, and one is numeric. You know numeric already. That's the adult one, 0 to 10. Well, the FLAC scale is from 0 up to age 3. It's also nonverbal children, which means it could be an 18-year-old cerebral palsy child who's nonverbal. They're still a FLAC scale. They can't tell you what's wrong, okay? And what it does, it looks at the faces, the leg movement, activity, the cry, and consolability, okay? And there's a score that you measure it in, and it works really well, okay? The second scale is from 3 up to age 8, but know that any person over the age of 3, it could be an adult, use it if you want to, it doesn't matter, but the FLAC has to be used for the younger kids. They can't use faces. They don't know how to do it. But older kids can use this. It's called a Wong-Baker Faces Scale. And you'll see it in 0246, or you can see it with all the numbers, but it's all of those pictures. And to see a little kid point to a number 7 to 9 and see that sad face, and you see them, you know they hurt. So, pain scale must be registered, and then we can give pain medicine, and then we got to make sure that we evaluate it. As I said, FACES scale is 3 and higher, nonverbal, and younger kids are going to be FLAC, and children at age 8, they say, can start using the numeric. Just like adults, children have all sorts of pain, chronic, recurrent, persistent. I mean, think about a child who has osteogenesis imperfecta, chronic brittle bone disease. They're in chronic pain. Reoccurrent could be sickle cell. I mean, there's all types of pain that be coming over and over again. The problem with pain that's not addressed, whether you're a kid or whether you're an adult, it affects every area of your life. So, as I said, sometimes children with problems with communication, sometimes there's this different checklist, but again, you can also use that nonverbal, that FLAC scale, okay? Pain management and the non-pharmacological, right? So I said it's not just the morphine or the dilaudid or the fentanyl. It's also ibuprofen, acetaminophen, cold, heat, elevating the head of the bed, turning, positioning, rubbing, all of those things can help. Distraction. Think about a child who's 4 years old and they're hurting. You gave them something for pain, and then you give them an iPad with their favorite game on it. They're going to forget all about they had pain, aren't they? That's what we can do. We could put on their favorite TV show, or we could give them a game to play. I mean, distraction, distraction, distraction. Infants, what has been proven by Harvard physio psychotherapists or whatever they were, but they're from Harvard. They did this big study. It was a scholarly type of research. They found that in circumcision in males, they looked at children getting a pacifier for their pain management and other ones that had morphine. There was no difference in pain control. So it's just better to give the pacifier with a little bit of sugar water on it, and it works beautifully. Another thing with pain is this kangaroo care. You can't see that but a little head of that little baby. It's skin to skin. It's the most wonderful things to see, where you have this irritable, premature baby and can't get comfortable. Mommy comes in, we put it in their lap, intubated, all the lines, everything, yes. Put it on their little chest, and all of a sudden their heart rates go down, their blood pressures go down, they just go to sleep. It's just wonderful to watch. It works. As I said, acetaminophen, ibuprofen, all sorts of different things we can use. Those patient-controlled analgesia, those are those pumps. Mostly those are used for older children. We use a lot of transdermal type of numbing stuff. We use Let cream, Emla cream, all sorts of things in order to numb areas, okay? And it's basically, this is a girl who's going to be getting a lab, and she's sitting there smiling because that little white blob is a numbing cream. She's not going to feel the pinch. She'll feel the touch, and she's not going to feel the pain. Kids have pain everywhere. I think ears are probably some of the worst pains that they can get, but it could be a little bit of anything. So, which of the following is most important factor in consideration in understanding the pain experience in children? They're not going to admit they're having pain because they don't want to pinch or they don't want to take the medicine. So let's do our first cahoots, okay? Who wants to win a cahoot tonight? Katie wants to win. Brittany wants to win. Madeline wants to win. Oh, Megan's smiling. She want to win. All right, let's find one for you. So you need a phone and your computer or another device and a computer. You can either go through this little code thing here, or you can just go to kahoot.it and enter the number that I'm going to give you right now. You'll put your phone on the camera on that little UPC, you go straight to it, or go to kahoot.it and then put that number. You will be getting the Kahoots. These are a great tool for studying. A lot of good concepts are here. If you can answer these questions, you can answer quiz and exam questions. Know that I don't look at the scores. I don't go back and see how many wrong, how many right. This is here for you to test yourself, okay? No other reason. There's no alternative motive here at all. The leading cause of death from unintentional injuries in children is unintentional injuries. Now, from age infant up to adults, the biggest thing that's going to cause the injuries is motor vehicles. Think about motor vehicles, car seats not put in right, younger kids being rolled over. I've seen many of them. They're either in it and on it or under it. And then you get up to adolescence and now they're driving. Motor vehicle fatalities, number one. And for those reasons. Which statement is most descriptive of pediatric family-centered care? What is pediatric family-centered care? What does that mean? So remember, family-centered care says that family is the constant. It's the only thing that this child knows. The culture, the words, the clothes, the food, they just know family. That's their constant. The major cause of death for children older than 1 year is think about children. They're now one, they're mobile, they're moving. And it's called unintentional injuries. You know, I call the toddlers my dive bomb kids. They can go from the couch, they want to jump over to the other couch, they miss, they land up on the floor, they hit the coffee table. This is what toddlers do. The nurse caring for the child in pain understands that distraction So distraction must be developmentally appropriate. For instance, to distract an infant in pain, I wouldn't give him a sticker, but I would take a rattle and maybe shake it. I would give a sticker to an older kid or give them something else. Remember, it must be on their level. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? They're playing all together, no goal. What is that? And I'll tell you, it's preschoolers. That's associative play. Parallel, they're not playing engaged and they're not there. It's next to each other, not touching each other, not playing with each other's toys or the other kid. Which statement best describes the process of critical thinking? I remember listening to Dean's giving this prep talk, to new nursing students about learning how to think critically. And I knew students were like, well, maybe I'll figure out what critical thinking is. Well, you do critical thinking every day. You had to come to my class today. You had to know where to find the Zoom link, how to put it in the Zoom and get here. That's all critical thinking. That's all goal purposeful, and it was goal directed. What is probably the single most important influence on growth at all stages of development? Nutrition, nutrition, nutrition. Good job. Which function of play is a major component of play at all ages? What did I tell you about play? What do they do with play? Play is all about the touch, the exploration in the mouth, because that's how they explore the world, and the moving of it, and figuring all that. It's all about cognitive development. It's creative. It's socialized. It's intellect development. Okay, sensor and motor activity is all about play. How do you apply nystatin to an infant with thrush? I throw this question in to show you the differences between an adult and an infant. So they've got that thrush on their tongues. It's this white stuff that you can't scrape off. And an adult, you would swish and swallow, right? Well, what would an infant do? And what you need to do is they can't squirt it in. You don't swish and swallow, none of that. You take a cob and you put it exactly where the area is. That's how you put it on. That was the difference. 3 children playing a board game would be an example of what type of play? A board game. 2 or more children playing together with a board game. Somebody's going to win. It's cooperative play. Excellent. The head to tail growth, direction of growth is referred to as from head to tail. What do you look at the words? Look at what the words say. Cephalic is a head, right? So cephalocaudal, it means they start lifting their head up first by 2-3 months, and they stand on their feet, attempting walking by 12. That is cephalocaudal. What is the single most important factor to consider when communicating with children? The child's developmental age. Good job, guys. What 2-year-old child pain assessment tool should the nurse use? For a 2-year-old, what am I going to use? And it's called a FLAC. FLAC is because they can't point to a picture and show me it yet. Faces starts at 3. You need to know this one. At 6 months, an infant's birth weight should do what? This is one of our growth and development milestones that we'll be looking for, and it should double. Excellent. It triples at 1 year. The first expected fine motor developmental milestones for infants begin with. First thing they do is F for fingers. So what do you think the first thing that they have? Remember, cognitively, they've got to somehow do it, right? So what would be the first type of grasp that they would do? And it's what we call, it's a reflex. Initially, infants, if you put something close, they'll grab it. It's a reflex. Now, if you're ever in a newborn ICU or with a mother and a baby, don't ever tell them that when they grab their finger and they hugged it, they go, oh, my baby's hugging me. Don't tell them it was a reflex. Just say, oh, yes, your baby loves you. Okay? Please don't ever share that one. Eventually, it's going to be a voluntary, but initially, it's a reflex. An 8-month-old infant should be expected to perform which fine motor skills? So we start out with that reflex. Then we go into a voluntary, and then we start with things picking them up off of a high chair, and we call them pincer grasps. It starts with a crude, we smush it in our face, and we end up with a little fine little thing. And this is the F for fingers. At 11 months, we should put stuff into boxes or pull things out. And by 12 months, we should be able to a block tower of 2. Okay. So they should be able to grasp the rattle, and that little crude, like putting the Cheerios in their face like that. But they end up like one by one. The natural physical developmental sequence that most children follow. So gross motor skills, physically, movement, what do they follow? What do they do first? It's up to 1 year old. What do they do from birth to 1 year old? Well, it starts with their head. So that was the first one. Then they roll, they crawl, they creep, they cruise, and they walk. Does everybody know what cruising means? So when you get on the side of a couch and you sort of walk down it and up it around a coffee table, that's called cruising, holding on to something. Which behavior indicates that an infant has developed object permanence? You know, this is a pretty neat thing. You take kids and you give them a toy and you hide it. They never forget it. They know it's still there. They're going to keep looking for it. Think about an older kid. You put their toys away in their toy box and they go to sleep at night. The morning they wake up, they go to the toy box, open it up, and there it is, right? So they will actively search for hidden objects because they know it's there. So it's object permanence in their brain. They know it. In general, an infant should triple their birth weight at what months of age? They will quadruple their birth weight at 2.5 years. So the first year it's triple, but it takes 2.5 years to quadruple. Amazing, isn't that? They slow down. Perform a head to toe assessment on a toddler before, most important to consider before beginning the examination. So a toddler, this is your young little 1 to 3 year old. You got to do an assessment. What do you need to consider before you go to that kid? And again, everything must be on their developmental age. And remember, get down on their level. And then use on toddlers, play. Use play for the assessment. They love play. According to Piaget, toddlers are in the blank developmental stage. Remember, they're still exploring. So if you're exploring your environment, which one is this? How do they explore the world? And that's the sensorimotor. Very good. You get it. Good job. Which intervention helps a hospitalized toddler feel a sense of control? I think the hardest kid to have in a hospital or take on vacation is a toddler. They don't like this different places, different routines. And because of that, take a hospitalized child, keep them on their same routines. Bath time, if it's in the morning, keep it in the morning. If it's at night, keep it at night. Same foods if we're allowed to. Let them bring in their things so that it's their normal routine. Do all children reach developmental milestones at the same age? Absolutely not. Thank goodness. Makes them unique. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for an infant? How did I tell you atraumatic care for an infant works? Doing a circumcision. Giving them an injection, starting in an IV. All of these things. And it's give that sugar water on a pacifier. Which of the following immunizations is administered to a newborn? Usually before they leave, and I know there's controversy now, they don't always offer it. I know there's new things, but according to the book, It's still hepatitis B. DTaP is at 2, 4, 6 months. The normal heart rate for a neonate is. Remember, as pediatric children, as the neonate becomes an infant, becomes a toddler, everything, the heart rate goes down. Blood pressures actually go up. So 140 to 160 is normal. To have a kid 180 crying, neonate, absolutely normal, nothing you need to do. What is the preferred site to give an injection to an infant? And I would hope there was somebody holding that child's hand, right? And it says vastus lateralis. We don't put them into their buttocks or to their arms till they're walking around more. The death of an infant under 1 year old with no known cause is called what? We're going to talk a little bit more about this next week when we have infants. And it is called SIDS, yes. The Vietnamese mother of a child avoids eye contact with a nurse, considering cultural differences. Why? I mean, these are the sort of little things that cultures are going to be showing you. You just have to be, observant about it. And then again, and as long as you talk to these children and parents, you gain respect when you ask. That is respect for them. They don't look at you. So a child from Mexico is hospitalized for a serious illness, and the father says the child's being punished by God. Why is he saying that? And it's absolutely normal. I've run and I've come from a very small town that didn't have like a lot of culture in it. And I moved to Miami. I was 24 years old, and I've had to learn so many cultures. And the one thing again is, when things happen, I was prepared because I was told things are going to happen. You just have to listen or ask. I had a good mentor. Which term refers to an individual's life where he or she is more susceptible to positive or negative influences? And it is actually called the sensitive period. Very good. What is characteristic of the pre-operational stage of cognitive development? So now we're talking about children that are a little bit older. They're not now toddlers, they're now preschoolers. Remember, preschoolers are still learning, right? They have got to see something first before they can understand it. And they call that concrete. Thinking is concrete. They've seen it, they can replicate it, they can do it. Concrete, you can see it, you can touch it, you can feel it, right? This is something they can't do it just by themselves. And last question, according to Kohlberg, children develop moral reasoning. What is this preschooler stage of moral development? So remember, infants and toddlers usually don't understand morality yet. It gets to those preschoolers that start to understand. And that is there's right, there's wrong, and there's a consequence for each. And it's also described as reward and punishment for these children. All right, let's see how we did tonight. Number 3 is Brandy. Good job, Brandy. Number 2, Jess. Good job, Jess. Number 1, drum roll, bing. Megan. Good job, Megan. Number 4, Madeline and Lexi. Good job, guys. So this is all I got for tonight. I'm going to be, sending your recording and information here. Again, anybody with accommodations, I need to know so I can set up your quiz for next week with extra time. And I need the letter so I can send it to Dr. Brown for your exams. Any questions you need, please just send me a message and I'll get back to you soon. That's all I got for you guys. Good night.
We can get back into that Kahoot, correct?
I'm sending it to you. Don't worry. You will be
Okay.
getting it. Don't worry. You're going to get it all. More
Thank
than
you.
once. You're going to get it.
Thank you.
You're very welcome.
Thank you.
My pleasure.
Thank you. Fun class.
My pleasure.